Welcome. In this explainer, we're going to take a guided tour through the latest College of American Pathologists protocol for intrahepatic cholangiocarcinoma, and this is tailored specifically for you, the pathology trainee.
Okay, let's dive right in. We'll be working with the official CAP protocol, version 4.3.0.0. Sticking to this, make sure your reporting is accurate, it's standardized, and maybe most importantly, it's ready for any lab accreditation that comes your way.
So, we're going to walk through this protocol pretty much just like you would a real case. We'll start with the basics, the scope, then move step by step through describing the tumor itself, assessing how far it's spread, and finally, getting to the staging and all those ancillary tests that really guide patient care.
First things first, let's define our playing field here. What exactly does this protocol cover, and, just as important, when should you be using it?
To start, it's absolutely crucial we ground ourselves in the anatomy. This protocol applies only to tumors that pop up within these intrahepatic ducts. So we're talking about everything from the very edge of the liver right up to the second-order bile ducts. What about perihealar tumors? Nope. That's a whole different protocol.
This table right here, it basically lays out your entire decision-making process. Just think of it like a quick checklist. Is it a resection? Yes. Is it an invasive carcinoma? Yes. Great, you're in the right place. But this protocol is not for biopsies, it's not for precursor lesions like intraductal neoplasms, and it's not for pure HCC or things like lymphomas.
All right, now we get to the real heart of the matter, describing the tumor itself. This is where your diagnostic skills really get to shine. So a key distinction you're going to need to make is between large and small duct types. And this isn't just some academic exercise, this has real clinical implications. Large duct types, they tend to show up centrally with obstruction. Small duct types, on the other hand, are often these peripheral masses. And interestingly, they share risk factors with HCC, like viral hepatitis.
And when it comes to grading, the system is beautifully simple. It's a clear framework based on just one key feature. What percentage of the tumor is forming glands? More than 95%? Boom, it's a G1. Less than 49%? It's G3. That kind of reproducibility is exactly what standardized reporting is all about.
Now, beyond the type and the grade, you have to document these four key things. Focality, is it one tumor or are there a bunch? Size, and make sure if it's multifocal, you're measuring the largest one. And finally, extent, has it broken through the visceral peritoneum? All these details are the building blocks that are going to feed directly into that final T stage.
Okay, let's examine how the tumor is interacting with its immediate environment. This information is absolutely crucial, not just for the surgeon, but for determining the patient's prognosis.
And here we go. This is a really big one. A major update in version 4.3.0.0 you have to know. Reporting on perineural invasion is no longer optional. It's required. You have to assess for it, and you have to report whether it's present, not identified, or you just can't determine it. This is a big change to work into your routine.
So your invasion checklist is basically these two key items now. You're on the lookout for lymphatic and/or vascular invasion, and now you're also required to look for perineural invasion. A simple yes, no, or cannot determine is all you need for each one.
For margins, just follow this really simple logical procedure. Step 1, are they positive or negative? Step 2, if they're negative, which margin is the closest one to the tumor? And step 3, measure that distance. That right there gives the clinical team clear, actionable information about how complete the resection was.
All right, now we're at the part where it all comes together. This is where we take all of our findings and synthesize them to assess how well treatment worked and to assign that official PT&M stage. And listen up, because here's the other big change in this protocol version you need to be aware of. If the patient got neoadjuvant therapy, chemo or radiation before surgery, you are now required to report on the treatment effect.
The protocol recommends using the modified Ryan scheme for this, and this table breaks it down nicely. There are 4 scores you can give. Score 0 is a complete response. Wow, no viable cancer cells left. And it goes all the way to score 3, which means a poor response with a ton of cancer still there.
So the PT category is all about a combination of size, vascular invasion, and local spread. This slide breaks down each rung of that ladder. And notice this, a solitary tumor with vascular invasion, I don't care how big or small it is, it's automatically a PT2. It's these kinds of critical details that really determine the stage.
Now, when you're assessing lymph nodes, it's so important to remember that the definition of regional totally depends on where the tumor is located inside the liver. This diagram of the liver segments really helps visualize that.
A node that's regional for a right-sided tumor might actually be distant for a left-sided one. So the whole key here is knowing which nodes count as regional for right versus left lobe tumors. You find a tumor in a hilar node? Okay, that's PN1. But if you find it in a celiac or periaortic node, whoa, that's a different ballgame. That's considered distant metastasis, and it automatically bumps the patient up to PM1. That is a critical distinction to make.
And finally, let's cover the additional findings and special studies that really complete your report and give everyone the full clinical picture.
And please, don't forget to report on the background liver. Seriously. Findings like the degree of fibrosis, whether or not there's cirrhosis, or an underlying condition like primary sclerosing cholangitis. This stuff provides essential clinical context and can be just as important as the tumor characteristics for the patient's overall prognosis.
This right here really highlights the expanding role of pathology. Your report on ancillary studies like mismatch repair status or HER2 testing, it's not just another finding. It can directly unlock specific treatment options like immunotherapy or targeted therapy for that patient. You are a key part of the precision medicine team. And finally, I want you to always remember this quote. Your synoptic report is a vital, non-negotiable piece of the puzzle. We provide the precise pathologic data, and the clinical team uses that, along with imaging and everything else, to determine that final, definitive stage for the patient.
All right, that concludes our tour of the CAP protocol for intrahepatic cholangiocarcinoma. The big takeaways are those two new required fields, perineural invasion and treatment effect. So the question to leave you with is, how are you going to apply this to your very next case? Thanks for tuning in.